Welcome friends, today we will discuss about atrioventricular reentrant tachycardia. In this condition, there is an abnormal band of conducting tissue that connects the atria and ventricles. This so-called accessory pathway comprises the rapidly conducting fibers that resemble Purkinje tissue, in that they conduct very rapidly and are rich in sodium channels. In about 50% of cases, this pathway conducts only in the retrograde direction from ventricles to atria, and thus does not alter the appearance of the ECG in sinus rhythm. This is known as a concealed accessory pathway. In the rest, the pathway also conducts in an antegrade direction from the atria to ventricles. So AV conduction in sinus rhythm is mediated via both the AV node and the accessory pathway, distorting the QRS complex. Premature ventricular activation via the pathway shortens the PR interval and produces a slurred initial deflection of the QRS complex called delta wave. This is known as a manifest accessory pathway. As the AV node and accessory pathway have different conduction speeds and refractory periods, a re-entry circuit can develop, causing tachycardia. When associated with symptoms, the condition is known as Wolff-Parkinson-White syndrome. The ECG during this tachycardia is almost indistinguishable from that of AVNRT. Now the management. Carotid sinus pressure or intravenous adenosine can terminate the tachycardia. If atrial fibrillation occurs, it may produce a dangerously rapid ventricular rate because the accessory pathway lacks the rate-limiting properties of the AV node. This is known as pre-excited atrial fibrillation and may cause collapse, syncope, and even death. It should be treated as an emergency, usually with DC cardioversion. Catheter ablation is first-line treatment in symptomatic patients and is nearly always curative. Alternatively, prophylactic antiarrhythmic drugs such as flecainide or propafenone can be used to slow conduction in and prolong the refractory period of the accessory pathway. Long-term drug therapy is not the preferred treatment for most patients, and amiodarone should not be used as its side effect profile cannot be justified, and ablation is safer and more effective. Digoxin and verapamil shorten the refractory period of the accessory pathway and should not be used. This is a picture of A picture shows AV nodal reentrant tachycardia. B picture shows Wolff-Parkinson-White syndrome in sinus rhythm. C picture shows Wolff-Parkinson-White syndrome orthodromic tachycardia. And Wolff-Parkinson-White syndrome in D picture with atrial fibrillation. Atrioventricular nodal reentrant tachycardia AVNRT and Wolff-Parkinson-White syndrome WPWS syndrome. The A ECG, AV node reentrant tachycardia. AV node reentrant tachycardia. The mechanism of AVNRT occurs via two right atrial AV nodal input pathways, the slow S and fast F pathways. Antegrade conduction occurs via the slow pathway. The wavefront enters the AV node and passes into the ventricles, at the same time re-entering the atria via the first pathway. In WPW syndrome, there is a strip of accessory conducting tissue that allows electricity to bypass the AV node and is spread from the atria to the ventricles rapidly and without delay. When the ventricles are depolarized through the AV node, the ECG is normal. But when the ventricles are depolarized through the accessory conducting tissue, the ECG shows a very short PR interval and a broad QRS complex. B figure shows sinus rhythm. In sinus rhythm, the ventricles are depolarized through the AV node and the accessory pathway, producing an ECG with a short PR interval and broadened QRS complex. The characteristic slurring of the upstroke of the QRS complex is known as a delta wave. The degree of pre-excitation, the proportion of activation passing down the accessory pathway, and therefore the ECG appearances may vary a lot, and at times the ECG can look normal. In C. Orthodromic tachycardia. This is the most common form of tachycardia in WVW. The re-entry circuit passes antegradely through the AV node and retrogradely through the accessory pathway. The ventricles are therefore depolarized in the normal way, producing a narrow complex tachycardia that is indistinguishable from other forms of supraventricular tachycardia. In picture D, that is atrial fibrillation. In this rhythm, the ventricles are largely depolarized through the accessory pathway, producing an irregular broad complex tachycardia that is often more rapid than the example shown. Thank you, friends.